Good afternoon to all the dear participants and very rich, resourceful and experienced members in this esteemed panel. We would like to start on the issue of accessibility and affordability in the healthcare sector and use of technology, how we can make use of the technology to provide quality and affordable healthcare services to the people in our country. So, as everybody knows that we are a very populous and second largest populous country in the world, providing quality, affordable, equitable services, healthcare services to the big population becomes a very big challenge and a huge task. So, when we break down the entire health sector, we can broadly break down the health sector into several components like infrastructure, human resources, drugs, vaccine, pharmaceutical sector, IT. These are the main 4-5 big criteria in which we can divide the health sector. But technology, this is a big component which can actually bridge many gaps which are there in across all these sectors. So this technology we can make use to provide the affordable, equitable and accessible services, healthcare services to the people, whether it is in urban slums, remote areas, tribal areas, whether it is Himalaya or islands, forest, everywhere. And this is also going to be technology is going to bring a multiplier effect across all these subsectors of the health sector. Now we have Digital India program, flagship program of the Government of India, and if we take the health sector into that, so telemedicine, then teleophthalmology, teleradiology, these would be some of the components in the Digital India program for the health sector. But telemedicine we have been discussing since almost a decade. There are a lot of issues. We have learned so many good things from telemedicine. But there are some issues like when the setup is there, the problem which we find that most of the telemedicine, the specialist doctors, they are mostly concentrated from the medical colleges, and medical colleges they are overburdened with everything, right from the teaching profession, then the observing the OPD, IPD, then their CMEs, lot of other issues are there. So the specialist doctors in the medical colleges, they are not able to give much time to the telemedicine. So what could be option that we have, just like teleradiology, there are empaneled companies or well-known companies which are working in there, and they are the well-known radiologists, they are members of these panels. So similar kind of thing, we can also encourage startups of young doctors as well as well-experienced doctors. They can form their consultancy companies and they can provide the clinical solutions for the telemedicine. So rather than overburdening our existing hospitals or existing medical colleges, we can divert little bit load there because we have a lot of funds available in the public domain as well as in the private sector. So that could be one of the solutions. Now teleophthalmology, we are one of the states where we started teleophthalmology since 2006, and it is running very successfully. So every year we are treating almost 70,000 people from remote areas, tribal areas, with a very few limited manpower. We hardly have only 20 ophthalmologists in entire state. So with that limited manpower, we are managing our entire eye care services, starting for diagnosis and treatment of cataract, whether it is corneal disorders or the disorders of the retina. Everything is being managed with the help of teleophthalmology. The joint secretaries from the Ministry of Health and Family Welfare, they have visited our ophthalmology centers and they have appreciated it. So now we are very happy that it is being replicated in other states. Similarly, radiology. Now some of the components which I think are going to be more important in the radiology is giving minimum volume to the interested bidders. Like government has to assure that with a minimum so many number of X-rays has to be, or CT scan, minimum volume has to be guaranteed to the service provider. Some of the other solutions could be that whenever the reports are ready, these reports not only to be shared with the doctors in the hospital, but with the help of email or through mobile SMS, we can also share our X-ray images or CT scan images as well as their reports to the patient. That is also going to be an important component because patients, they can preserve not only the hard copies but soft copies for their future use, and whenever they are visiting to some other private hospital, they can carry the same reports and other things for their purpose. Teleradiology, one beautiful aspect is the software of the radiology. There are almost more than 100 solutions available in the teleradiology software. So it's an excellent use of technology for providing healthcare services. And just to be discussed with Dr. Sharma, telesonography. Tamil Nadu is a state where they have successfully used the telesonography, and the biggest problem is that was the PMDT Act, PC-PMDT Act. But now Government of India, they have almost resolved this issue of PC-PMDT for use of telesonography. And once this telesonography is used successfully, it will be useful for diagnosis of prenatal diagnosis of birth defects in children. Dr. Rajiv Jain is the director in the Ministry of Railways to share his perspective on the health assurance and accessibility of the healthcare services. So.
I must thank ELEX as well as the moderator for creating a ground space where we can actually discuss the crucial issues of affordability, accessibility, and I would extend this to efficiency as well. In the context of universal health coverage and health protection, with the overlay or underplay of efficiency and affordability, it is incumbent that there should be a functional system on the ground. And what is this system, health system that should be available on the ground? There should be primary, secondary and tertiary level facility where with linkages. What I'm hinting at is the linkages where referrals are ensured based on the assessment at a particular level. We in the railways, as such, Indian Railways was lucky to develop a system of this nature with a long period of time. In fact, right from pre-independent days, and over last, say, 163 years, it has been able to build a very robust infrastructure all over the country with 125 hospitals, 40,000 beds, 585 health units, and over that, few of the best tertiary level facilities like cardiac surgery, orthopedic surgery, neurological setup. Over the period of time, this system has been amply supported by having health as a matter of right, not as a matter of convenience. That is, the person who works for the Indian Railways, a good number, being the largest employer in the world, 1.4 million employees, by virtue of being an employee, he continues to be having a fundamental right to have full access to healthcare without investing anything from his pocket, from his salary. And not only that, he is ensured of an ecosystem where he is provided health promotion, health prevention, health rehabilitation, and disease management. And I'm repeating this: health promotion, disease prevention, if you suffer from some disability, rehabilitation, and disease management in one single ecosystem without the risk of financial jeopardy. Now, if this system is available all across the country, outside the railways, in the states and in other organizations, then health status of our population is going to come up to the Indian Railways level, basic parameters, death rate and birth rate, are at par with few of the Scandinavian countries. This is possible only through a robust, continuous investment in healthcare, infrastructure, manpower and training. Now, if you have this system in place, only then technology can help you in further improving efficiency. Technology as such will not improve the quality of care if the system is not in place on the ground. Which I mean, like, there should be primary, secondary, tertiary care with linkages. Functional linkages, that is, a person goes from primary to secondary and goes back to the primary, and his whole lifespan on longitudinal in the time scale is trackable. We are able to track a person over a period of say 25 years, and we are able to track him post disengagement from railways. He continues till he dies, he continues to be engaged in the railway healthcare system all through his life, and that too without investing. Take for example, one of the retired railway officer, he had a colon cancer, and the total treatment cost for that particular treatment was about 2 crores rupees. Yet he did not have to shell out a single pie from his pocket. The entire cost was borne by the railways because of he being a railway employee or an officer. And there are a umpteen number of examples of this nature. When we scale up health protection for our country, when we talk of universal health coverage, one has to talk of revenues. You have to generate revenues to ensure that this system works all the time in a predictable manner. Fortunately, railway has its own revenues, it's not dependent on general exchequer, which means the business of railways, that is the passenger and the freight, contributes to efficiently manage its healthcare system. And then if I do not talk of occupational health system, if I do not talk of a trackman having access to not disease-specific screening, but comprehensive screening for health promotion and health education, that will ensure a sustainable and cost-effective healthcare delivery. Technology only helps to a certain extent. That, for example, like we had a model for telemedicine, where from Perambur Southern Railway Hospital, we had consultants talking to NF Railway in Guwahati, and then delivering the care. We had from divisional hospital to zonal hospital, telemedicine contributing. But that can only add to a limited extent unless you have a system where the person, the remotest location, is also able to move up the scale and come back and continue to be engaged in the system all through his life cycle. I don't think the system technology is going to change the quality of care at the end and will lead to patient satisfaction. That's the way we look at it from Indian perspective, because we believe that unless the environment is created and the structures are created, only then creating technology backbone and investing in technology to deliver high quality care would be feasible. That's the point we hold, and that's the commitment that we in railways have, and that entire investment and return on investment, I would consider the health sector is one of the best in railways compared to other sectors, just because there's enough investment has not been made in linkages. Linkages, again, vertical, horizontal, and cross-sectional. I feel that makes a crucial change or crucial outcome which ensures, and ultimately the clinical outcomes and the quality of care is determined through these factors.
Thank you, Dr. Sen. I'll now request the panelists starting from the left to share their views on the given topic.
Dr. Sudhir Gupta. I am one of the founders and directors of Cygnus Medicare. We run a chain of 11 hospitals in tier 2, tier 3 cities. 7 hospitals are in Haryana, in district centers of Haryana, including Kurukshetra, Karnal, Panipat, Sonipat, Bazirgarh, and Tola. And 1 hospital in Bathinda, and 4 hospitals are in Delhi. Out of that, 2 hospitals are in the periphery, which we consider more like Haryana, because Nangaloi and Rama Vihar, the outskirts of just 2 kilometers beyond that, the border of Haryana is there. And accessibility and affordability, incidentally, are the base. We have 4 basics of our company: accessibility, affordability, quality, and dignity. That is the 4 things we work on. And incidentally, these are the 2 included here today. We incidentally come from Haryana, most of our founders, and we had seen over long periods of time that people die left, right, and center by 3 things. Number 1, trauma. Number 2, cardiology problems. Number 3, medical emergencies like asthma and other things. And so, in any of these districts, except perhaps Gurgaon, Faridabad, and Hisar, there was no facility of this kind that will tackle these 3 problems or similar problems, which hardly give any time. Maybe within 1 hour, if you don't get a treatment, you are no more there. And if you get a treatment within an hour, then you are almost healthy, like in cardiology, heart attacks, and stenting, and all that stuff. So with that dream we started, and with that dream we have approximately 100-bedded hospitals. All of our hospitals are approximately 100-bedded. We provide with medical ICU, with full-fledged medical ICU with intensivists all around. And we also provide with cath lab in most of our centers, and few of them which are left are getting the things. And more importantly, we have round-the-clock cardiologists stationed there. Not that a cardiologist is coming from Chandigarh or from Delhi. And thirdly, we have a trauma center, which is a full-fledged trauma center with a CT scan, with a full-time stationed neurosurgeon, with a full-time orthopedic surgeon, with a full-time general surgeon, and an radiologist. So this is the team which makes, including the intensivist and ICU, which creates a trauma center. So accessibility, this is brick and mortar. We are going there, and we are creating these centers there. But so far as technology part of it is concerned, we also want to take it to the next level, maybe Tehsil level and maybe PHC level. And we have been trying for the last almost 6 months now. We have done 2 pilot projects with 2 companies for telemedicine. We were trying to do it as you were saying, sir. In Patna also, that is what my experience was, that there is a paramedic who is sitting at these centers. We are now trying to do it another pilot with the same company who are providing it at Patna. And if we succeed, which we hope that we will succeed. Earlier, if we did not succeed that much, there were a few reasons for that, which we are trying to negate now. So technology will create more accessibility in our case. That is what our experience is, that technology and telemedicine especially should definitely be utilized for creating more accessibility. Now, coming to affordability, I think affordability is a huge issue. When you go to tier 2, tier 3 cities, the affordability actually gets a jolt, because the doctors, if they want to go there, they are charging more as compared to they are charging in Delhi. Means that if I get a neurosurgeon for 2 lakhs in Delhi, Dr. Saraswat would know, I get the same neurosurgeon for 4 lakhs a month in Kathal or Kurukshetra. So my affordability goes for a 6. And similarly, other professionals also, including nurses and all. So affordability, but we took the route that we studied the models of most of the hospitals very carefully, and we came to the conclusion that most of the affordability, or most of the cost that goes in building a hospital comes from the land and the building. So we did not invest anything in land and building. We just took the already existing buildings of a few hospitals or from Greenfield also, and we did not invest anything there. We invested only purely in manpower and in the equipments, and the best of equipments that were required there at that for So that is how we took the route to affordability. And we also realized that even the other facilities, similar facilities like general surgeon or orthopedic surgeon, which were existing in these towns, which were not providing intensive care, but still they were existing, the quality was a big issue. Although they were at times more, they are still a little more affordable than us, few of them, but quality is the issue. So we ensure that we provide the best possible quality. Now we may say that we are best possible, but you have to have some standard. So we have applied for NABH in all our hospitals, and we will be getting NABH certification for 2 of our hospitals in April. Already the final assessments have taken place, and we are going for the rest of the 9 hospitals also. But it is a huge task, which we, it's a huge challenge, I would say, to really make the things affordable and provide quality also at the same time. So it's definitely an issue. But there is the opportunity we saw, because there is a lot of there is no facility of this kind available in the whole district places. So this is what our experience is, and I think we will take it further with telemedicine and other things. I mean, of course, there are so many things which have been talked since morning, which of course are being used by most of us.
So time is also a limit for us, so I'll request the next speakers to stick to the time.
I'm from Kolkata. My organization is Medica Hospitals Private Limited. The main hospital being in Kolkata, Medica Super Specialty Hospital, 350 to 400 bed hospital. It is going on, so I cannot mention the bed number of beds right now, because it will increase in coming days. We have other hospitals in Ranchi. It is again it is a big hospital there. In Jamshedpur, 2 in Siliguri, 1 in Kaliganagar, and all of those hospitals has been built up and acquired in last 6 years only. We are a 6-year-old company, and we have 6-7 hospitals, and we are also catering abroad, Bangladesh and all. We are going there, and Middle East. So now, I will come to the subject. If you talk about technology, we have implemented a lot of technologies in our hospitals. A lot of technologies means the basic HMIs is there, eICU is there. We have implemented eTag on basis of NFC, what was being discussed. The doctor has to go to the patient, otherwise he will not be charged and all. We have started from the basics, and we are going on implementing new things on it. We have also integrated laboratories and everything on the system and on the portal. We have also integrated HL7 non-HL7 platforms, equipments to HL7 platforms. We have put middlewares, and we could connect the machines to our non-HL7 platforms also. Everything is done, or some of the things are ongoing also. But if we come to the affordability part and accessibility part, I am really surprised that where we stand, and I actually come into confusion that what should be done in the next step. Because if you talk about our hospital, if you talk about my my hospital is assessing me, I am doing a very good job and everything. The IT department is doing a very good job there. But in terms of catering these services to the public, where affordability and accessibility is being talked of, is really a very big challenge. In the country like us, where we don't have sufficient number of doctors, sufficient number of nurses in place, we have a very variety of population distributed among geographical areas, distributed among financial income, and also the accessibility of the patient. He lives in a mountain or in a forest or in an Naxalite area. So affordability, accessibility is a real challenge. And in this front, I will just tell that if we want to go ahead with technology adoption, first we have to start with the operational and clinical members of the team, of the organization, of the government, of the rural healthcare providers. Everybody has to come in a single platform which government has to obviously look at and frame some policies on it. Then only we can go ahead with it. This is one of the point of what I wanted to discuss. Because of time, I am not elaborating it. Number two, what I would tell you that you can see all the across the industries, IT is leveraged in a manner that every industry have reduced costs, has reduced their, has increased their efficiencies in terms of manpower, in terms of delivery. But this reduced cost is being delivered to the endpoint customer or not, that is a matter which has to be taken care of. Again, there is a government initiative has to be taken up. We cannot do anything on this. We are a corporate hospital. We have government hospitals also in the area. We have the third, grossly if we divide, we have corporate hospital, we have government hospitals, and we have rural healthcare initiatives, and also the doctors who are not certified by the government. So we have to take care all the platforms. We have to come into a synergy to go ahead. Point number 3, I would mention that we have all of us have developed certain technologies and certain softwares or whatever in place in terms of delivering healthcare effectively to the population. But we have failed in number of cases. Failure is inevitable in anything when you are managing a change or you are changing anything, any new initiative you are taking up. But that failure has to be a time-bound effort. That failure has to be converted into a success in a minimum period of time or in a minimum cost period. So that failures are not noted down, as I think. If we note down those failures, we can learn some lessons and we can do something better for the society in future. I would just end my discussion here. We can take any questions offline.
Questions will take later on. I still allow the other speakers to present their views.
I am Dr. Sivakumar, representing Kovai Medical Center, which is a 1,000-bed hospital, running for the past 25 years. We have did a lot of technology implementation in our hospital, right from eICU, paperless ICU, electronic medical records, and introducing the app for booking the appointment, changing the appointment, meeting the doctor. All those things we have given, we have implemented on a phased manner. As the other people have told, when you are introducing the technology, definitely the quality is going to be improved, but the affordability is in question. There is a sort of a balancing activity needs to be done. One side is the quality, another side is the investment for getting this quality. This is going to be a challenge for all the hospital administrators. The technology is improving quality without any doubt. We have got 4 centers outside the hospital, outside the main center. The electronic ICU, that is eICU, is doing a lot of help for the people who are not able to afford, who are not able to reach in time. They need not have to travel all the way from their villages or peripheral centers to the main center for getting the treatment, and the expenses on coming from one end to another end, bringing the relatives along with them, staying and other things, all those things are definitely saving the patients, and then the affordability becomes very easy for them. Any patient who is getting into our emergency, all the vital parameters are getting recorded from the moment he is entering into that, and then it is being passed on to the main center while they are coming from there only, so that they can, the experts can advise the patient, advise the doctors who are on the ambulance to take whatever is the emergency steps needs to be done. By that way, we have invested heavily on the capex, on the equipments, on the technology, but this facility is not being charged anything extra to the patient. By that way, we have made our affordability little access to patients. The electronic medical record, which is being done, we have introduced a smart card to the patients. They can now it is going on a trial basis. They can try within the Coimbatore, but the other areas we are trying to explore the possibilities of extending these medical records to be accessible at all over the India. But this is in the project stage. This is being implemented. The paperless ICU is again giving a very quality work. Most of the equipments, high-end equipments, are getting connected, or they are talking to the HA system, and then the vital parameters which needs to be taken by the ICU nurses. They can spend a lot of time. I mean, they can save a lot of time by not doing this, because it is getting automatically done, and then also it gives the, if you fix the frequency or the intervals at which it has to be taken, it is taking automatically, and then it is passed on to the HA system. And even you must be all knowing that in ICU there are a lot of paperwork which is being done, and then a study shows that 40% of the nurse's time is being spent only on documentation. So this paperless ICU is going to save a lot of time for the nurses, and they can spend a lot of quality work towards the patients. This is what the technology, what is being implemented in our hospital. We are always on the lookout for new technologies, and this is a sort of a journey, and this is not a ending point. Thank you.
I'm Dr. D.P. Saras, working with Shibalaji Action Medical Institute and Action Cancer Hospital. It was a delight to hear the panelist with me. Let me now bring you to the national level rather than talking at the institution level. We talk of affordability and accessibility. Accessibility is what? Where the person has a medical emergency, or he knows the cost of treatment is very high, which is beyond his reach. Now, to get the treatment for these people, either the person moves to where the healthcare delivery system exists, or the healthcare existing delivery system reaches to his doorstep. How he pays, how he can afford. When we talk of affordability, affordability for him is something else. Affordability for me or for the person who is opening the gate when we entered is something else. If for cardiac emergency, I can spend 2 lakhs for getting the BTCA done, but that man probably cannot. That is affordability. That means I assure that if you are under our care, we'll treat you at the cost you can afford. That is my understanding of affordability. Now, it has to be seen in this prospect. Now, having heard all this operational efficiencies, you save on man hours, in turn it converts into operational efficiency. you bring down the cost of operation. That means you can, in the same amount, serve or deliver your services to larger people. Now there are two things. The people, what we are talking, we are in a metro cities like Delhi, Calcutta, or other places, where people in any case have a wider choice. They can go to the institution where they get the treatment which they can afford. For a moment, let's keep that aside. Let's talk of rural area. Let's talk of urban slums, where affordability is the issue. And we want to improve the accessibility. Where is the problem? Problem is, and how technology can help us. And somebody very nicely said that technology is not going to treat the patient. Technology is an enabler. It helps us. A person who is sitting in a remote area or a little far away from our destination, and we say, all right, telemedicine, telepathology, that's okay. But who is going to do the serum cholesterol for that person? I want to get the CT done. I want to know whether he has a stone in the gallbladder. Because where he gets his CT done, once the CT is done, then you can transmit the picture anywhere word over. Take anybody's opinion at any cost. All these things will come a little later. Now, where is the nearest CT scan? The other thing, I have been here for last 5-6 years, to be precise. We have been hearing the government is taking this initiative. I have met some people who are driving this IT initiative at the government level. I do not know, in 6 years, nothing is visible and perceptible at all. From Paytm, I want to buy a pair of shoes. I select the product online. The money is paid from my account to his account, and the material is delivered to me. And how much I have paid, none of you can check or find out how the money transaction has happened and how much was the amount which was transferred. When these people have taken an address, taken care of an address, the privacy issue and confidentiality to that extent, where's the worry of sharing the health records? Tell me. How much from Zepic.com or Paytm or so many e-commerce sites are there? They have perfected this art and skill and competence, and they have experience to their credit. We have to just borrow. Indians as it is, we are not inventors. We are expert in copying the, why not? There's no harm. There's no matter of shame or complex that we borrow the technology or understand the knowledge of technology which is widely being practiced. Do that. And we can start it from tomorrow onwards. Another thing, sharing the medical record from one place to another is also a hype is being created. Is it really required? See, as a railway, whatever, a senior medical administrator, I've been a retired colonel in organized sectors like armed forces, railways, where there's a graded medical care, and you decide where your employee will be sent for next level of treatment. All these things make sense. But in our hospital, in a private sector now, somebody in a village, which may be just about 8 or 10 kilometers away from a hospital, but no facility, he doesn't get even a drinking water, there's no tap in his house. He gets a MI, and where we are talking about a graded care and transferring of medical records for that person. It just comes, and some of these people, I mean, let's not underestimate, all of them are not poor. Some of these people, I'm witness as a CEO, these people come, open a bag और पैसा लेके सामने रख देते हैं, डॉक्टर साहब ये पैसा रखा है, ये मेरा बेटा है, इसकी जान बचानी है आपको. Money is not an issue. Scenario is different. I treat him, we treat him, do our best. Now, why I am changing my discussion? that all this is happening because affordability is different, accessibility is different. But all this is needed because word over, the Western world is doing it. We should do it. So these are some of the challenges and their solutions right in front of our eyes. Let's borrow that, adopt, and that's my humble submission to people who are decision makers and thinkers and the deciding the future of our country. Thank you.
Hello, I brought greetings for you all from the vibrant state of Gujarat. I'll just talk on two schemes which was started by then Chief Minister, now Prime Minister Modi. One is Mukhyamantri Amrutam Yojana. It was started 3 years back, and you can thought of, we are talking about accessibility of healthcare, affordability of healthcare. This scheme is a cluster of 15 specialties, right, from oncosurgery to cardiology and so on. And every BPL family is a part of this Mukhyamantri Amrutam Yojana, which is to the tune of 2 lakhs, and you believe it. OPD consultation, diagnostics, indoor hospitalization including the complex surgeries and follow-ups, plus you have to also arrange the transport of the patient to the homes from wherever they are coming. So this, what government started 3 years back, and all the private hospitals, all the public hospitals is supposed to empanel with them. So this scheme is happening very well, and most of the time it has been seen, outstanding has not been clear. But I have seen personally, I represent Sunshine Global Hospital, which is the fastest growing chain of hospital in Gujarat, which is in Vadodara, Surat and Bharuch. And payments we get just within 2 weeks. Number one. Number two, school health program, which was started by the state. And there's a good mix of public and private health partnership, in which all the district used to screen the school students, and then they've been treated for the cardiac surgeries and for problem of nephrology in one of the premier hospital of Ahmedabad and Vadodara, and the payment is given by government. So these kind of things are available, and I have seen in the last 15 years of healthcare, the cash to credit. Earlier we were having around 70% cash patient and 30% credit. Now it is around 55% credit. Most of the patient will coming under the net of various government scheme or any insurance companies. And in the recent budget, from 30,000, it has been raised to 1 lakh for a BPL family. So I feel government is also very much positive about that, and a good public and private interface has been made. But cash flow is a serious problem. Some of the government scheme like ECHS, CGHS and all, if you see the outstanding of a private corporate hospital, some of the hospitals to the tune of 75 CR. So which make most of the hospital, like some of this hospital in Hyderabad is on the verge of closing down. So these are the things which I think from the government has to see. CGHS rates are very low, and you are not getting payments on time. Otherwise, some of the schemes are working fantastically well, and we as private players should support. Thank you.
Hi, I'm Alok Khare. I look after IT part of the JP hospital. I joined this hospital when the hospital foundation work was started, somewhere around 4 years ago. And when I joined, my CEO told me that the difference between a good hospital and a great hospital is information technology. So this is the way we started the hospital, and I ensured that the IT infrastructure part, which was the requirement at that time, should be robust. And we did, in my opinion, we did very well, like in terms of IT infrastructure part. And I think everyone will accept that, okay, that is important. Afterward, we focused on the HIS. Basically, HIS, I feel, is a bread and butter. Any hospital cannot live without a good HIS. And the EMR part of the hospital, yes, we are struggling, like anyone is struggling, and I believe that EMR will take its own time. And whatever best or good EMR system you have, it is very difficult to achieve 100% whatever the doctor entry online. And I'm not very sure whether that is really going to give a benefit the technology for patient. When you are not seeing the patient eye to eye, he will not be satisfied, he will not be happy. He will think that what I was doing in front of computer. So actual online EMR is really, I'm not very sure. these are the metrics. Okay, using that, if you improve on these metrics, for example, turnaround time, affordability. Like, okay, suppose patient wants like okay, low cost medicine. So we also propose like okay, if you achieve like if you start giving 10 to 15% discount to the on the pharmacy items, then you can because it is available also if you are not using any business. So that also can be. So we identify the parameters for these patient areas, and then we track these parameters on a regular basis. And these parameters basically is converted into matrix for the hospital. From the hospital matrix, it is converted into department matrix, and then based on like okay, we set up the target for those matrix, and then see by improving those targets, by achieving those targets, how much patient delight can be achieved. So this is the basic process and philosophy we are using for patient delight and in any other parameter. So why we have to bring other industry best practices to the healthcare? Because I feel that if you see the healthcare is not very matured IT vertical. It is if you compare with the banking, insurance, manufacturing, or any other thing, healthcare will be. It is not very much mature. But one way it is good for this because we are able to use the latest technology. When we are starting IT implementation, we can use latest technology. We are using that is the reason we are able to use the labs very fast. While actually in other industries, if you see manufacturing and all, we are depending on other the portal and all. While here actually the hospital we have implemented directly the website without having help of any other portal. So this is the way actually. This is our we are only 1 year old. Hospital is operation for last 1 year. But the way we were trying to achieve, we have achieved little more. We have to see like what
Thank you. So, technology for patient delight and making healthcare affordable and accessible to all. So, all the esteemed panelists as well as all the audience, all of us would be very delighted to know that it is not only the government sector or the public sector which is trying to make the healthcare sector affordable, but it is also the private sector, private hospitals, group of hospitals, by following different models of the financing, like where to invest exactly, how to reduce the cost. So that's how these are the different models where we have seen that Dr. Gupta and Mr. Syed Murshid, they explained how they are trying to making an effort to provide affordable and accessible healthcare to the people. So similarly, Dr. Saraswat mentioned that it's a right time to launch the EMR by properly addressing the two issues of privacy and confidentiality for organizing such a wonderful and beautiful program for us. Thank you.
Thank you very much, Dr. Sandeep. This discussion on technology making healthcare accessible and affordable. And this was the last session of this conference. I would now request session moderator, Dr. Sandeep, to present mementos to eminent panelists. Cancer Hospital. Dr. J. Sivakumaran, COO of Kovai Medical Center and Hospital, Sunshine Global Hospitals, Gujarat. Dr. Sandeep Gupta and Mr. Alok Parekh, Vice for a wonderful moderation for this session on accessible and affordable healthcare.